current lecture will introduce you to chapter 21, which covers the urinary system and will present its role in maintaining the blood pH, the body fluid osmolarity, and maintaining the normal blood pressure. An overview of the current lecture, including a presentation of the excretory system that will include urinary, digestive, respiratory, and integumentary systems, describing of the anatomy of the kidney in terms of structure, as well as the physiology of the urine formation at the level of the kidney, urine elimination process with a description of the ureters, urinary bladder, and urethra, types of discussion regarding the urine in terms of normal and abnormal findings, disorders of the urinary system, including obstructions and structural disorders, inflammatory conditions, polycystic kidney disease, neoplasms, renal failure and its treatments, and incontinence, and aging as it pertains to the urinary system. Please take a moment and stop this presentation in order to review the learning objectives for Chapter 21, Urinary System. The urinary system is also named the excretory system because the main function of this system will be to eliminate, to excrete, to remove any type of unwanted substance, and by doing that, cleaning the blood. In addition to that, the urinary system is involved in regulating the volume, the acid-base balance, the pH of the blood, as well as the electrolyte composition of the body fluids. The main structures of the urinary system, as you can see in the image, will include the kidneys, the ureters, the urinary bladder, and the urethra. We have a paired organ, that is the kidneys, that will actually perform the function of cleaning the waste products from the blood, will maintain body fluids balance, and will form the urine. The ureters are also a paired organ that will transport the urine formed from the kidneys to the urinary bladder. The urinary bladder, as opposed to the previous ones, is a single organ positioned in the middle lower part of the abdomen in the pelvis that will serve as a reservoir and will store the urine brought in by the two ureters. And urethra will be also a single organ, and this is a tube that will conduct the urine from the bladder to the outside of the body for in the process of elimination. So I was telling you that urinary system is the main excretory system that is involved in the cleaning and elimination of waste products. However, we need to remind here the other systems that we described before, and I will start with the first one that we described, and that was the integumentary system that included the skin and all its associated glands that will help in removing and excreting water, some salts, electrolytes, and very, very small quantities of nitrogenous waste. This happens all the time through the process of perspiration, and that allows the water to continuously evaporate from the skin. The second system that we described was the respiratory system, that is the main element of the body that will help in cleaning and eliminating carbon dioxide, and in addition to that, also small amounts of water. The water that is eliminated through the respiratory system will be in a form of small quantities of vapors, and it's eliminated. It's what warms and maintains a certain moisture at the level of the respiratory tract. The third one is the digestive system that is involved also in elimination of water and salts, along with bile and any type of other digestive waste products. Those will be eliminated in the feces. And associated with the digestive tract and part of the digestive system, we have the liver that is very important in processing many particles in our body, including the destruction of red blood cells and recycling of some of the elements that are part of the red blood cells, along with breaking down and eliminating or neutralizing drugs and toxins. Kidney activities can be seen as a wide range. However, the main and probably the most relevant function of the kidneys will be always uh, in relation to the cardiovascular system. Um, Inside the kidney's activities, we'll start by the most obvious one, which is the function of excretion. The kidneys will eliminate any type of cellular metabolic waste along with other toxins that may accumulate otherwise in the body, in the bloodstream. Um, Among the other metabolic waste, it's the one that is standing out is the a product of the metabolism of amino acids in the process of deamination of the amino acids in the liver. The byproduct, the result will be a compound that is called urea. And once synthesized in the liver, the urea will be transported through the bloodstream to the kidneys and will be eliminated at that level. In addition to that, we already established that the kidneys have the capability of maintaining and changing the body fluid balance, and by doing that, maintaining the homeostasis of the body fluids by altering the amount of water and sodium that will be eliminated. So the kidneys have the ability to either concentrate the urine or dilute the urine and eliminate uh, variable amounts of sodium in order to satisfy the needs of the body. Along with that, and in the line with that, the kidneys also will be able to maintain the homeostasis of the acid-base balance in the body by eliminating more or less acids, more or less base, or by producing more buffers in order to maintain a very strict and narrow pH that our body needs for a good functioning. Kidneys are also involved in the blood pressure regulation, and they can do that by altering the body fluid balance. And we'll discuss that in depth a little bit later. We have also hormone production at the level of the kidneys. They will produce erythropoietin, that is that hormone that will stimulate the production of red blood cells at the level of the bone marrow. They also will be involved in activating vitamin D that is essential and for the health of the bones. Individuals that may have a condition that impairs the structure of the kidneys will, as in chronic renal failure, they will have an inefficient production of erythropoietin. They will be deficient in that, as well as in the ability of the kidneys to activate vitamin D. And as a result of that, they will need to have that provided from artificially from the outside. Um, Without the erythropoietin provided to those type of patients, they will suffer from anemia, from an inadequate production of red blood cells. The red bone marrow will not going to be activated, as well as of weak bones, as in osteomalacia or osteoporosis. The last part where the kidneys are, the last element where the kidneys are involved will be the blood glucose control. And it's interesting that kidneys can synthesize glucose from a non-carbohydrate source, like amino acids or glycerol or pyruvate or lactate. So it's in very small quantities. It's only up to 20% and only in very certain conditions, because there is still the kidney, because the liver is still the main source for synthesizing glucose from non-carbohydrate sources, but the kidneys are also have this capability. We'll describe now the anatomy of the kidney, and we'll start with starting with the macroscopic, the location and the macroscopic structure of the kidney. Kidneys are a bean-shaped type of organ, and they are located in the upper abdomen. However, in the posterior part of the abdomen, they are considered an extraperitoneal organ. The peritoneum is covering them from their anterior side. They are positioned about roughly at the level of the last thoracic and first three lumbar vertebrae. The right kidney is slightly lower than the left one, again, because the liver is a big organ and it's pushing everything a little bit aside or down. Each kidney will have a membranous renal capsule that is made out of fibrous connective tissue. And in addition to that, there will be a protective layer of fat. It's called the adipose capsule that will surround the organ and will provide a cushioning and provides will allow the organ to not be injured whenever there will be um, um, any type of trauma in the area where the kidney is located. There is an outermost layer of fascia that anchors the kidney to the peritoneum and the abdominal wall and keeps it in place in addition to this fat. So the blood will be brought, if you see it has this kind of bean shape. It has a concave area and it has a convex part. The convex part is called the hilum. And at that level, just like in any other organ that has this type of structure, hilum, the renal artery and the renal vein, together with the ureter, will come together and will enter the kidney. We can say that the renal artery bringing the blood in is getting in, while the um, renal vein, because it's going out, will leave the kidney at that level. So again, you can see the hilum with the um, renal blood vessels and the urethra. Um, if we need to measure the kidney, roughly the kidney will be about 10 centimeters long by 5 centimeters wide and about 2.5 centimeters thick. That's 4 inches by 2 inches by 1 inch. Um, if we are going and looking inside the kidney structure and we are going into a more from macroscopic to a microscopic type of structure, from big to small, we can see that the kidneys can be divided into two regions. We have again an outside structure, an outside part of the structure that is called a cortex, the renal cortex, and we have an inside part that is called the renal medulla. Now, at the level of the renal medulla, we have the tubes in which the urine will be formed and collected. And those tubes, by joining together, will form a number of cone-shaped structures, and you can see them in this picture. And those are called renal pyramids. And they are called pyramids because they have this kind of triangular shape in the section. But when you look at them, like a 3D type of structure, you can understand why they are called a pyramid. The tip of this pyramid will point toward the structure that is called the renal pelvis. The renal pelvis is pretty much in the middle of the structure towards the hilum, and it has this kind of funnel-shaped structure that will end up by developing into what is called the ureter. There will be some cup-like extensions of the renal pelvis that will surround the tip of each of the pyramids. And those cup-shaped extensions will collect the urine. And because of that, they are called calyces, like the old, type of cup that the kings used to drink for them. So they are called calyces because they have this type of structure. The urine that collects in the pelvis will be further passed down the ureter towards the bladder. We are moving now into a little bit more in depth of the structure um, of the kidney. In order to understand the function, we need to understand the unit, the structural unit that will perform the kidney structure. And the basic unit that will actually produce the urine is called the nephron. And if you look into the picture down on your screen, you can see that each of those nephrons will begin with a hollow and a cup-shaped type of bulb. And this is called a glomerular capsule or the Bowman capsule. And the structure has this name, it's called the glomerular capsule because the glomerulus in Latin means a ball of yarn. Now, you can see that the unit of the glomerulus is made out of the capsule, and it provides a filtration device for the kidney. The rest of the tube, and you can continue from the glomerule with the long tail that you can see in the image. You can see that it's just a system of tiny coiled tubes in different types of diameters and in different types of positioning, and they are called the renal tubule. The portion leading from the glomerular capsule immediately, the first part of it, is called the proximal tubule. Proximal means the first one. After that, it will untwist. It's kind of coiled and suddenly will untwist into a structure that has this kind of hairpin shaped segment. And this segment, the whole segment, is called a nephron loop, or the loop of Henle. The first part of the loop will be a descending limb. You can see how it goes down, while the second one will be an ascending limb. One goes down, descending, and the other one is ascending, coming up. Continuing from this ascending limb, we have what is called the distal tubule. And it's called distal because it's further away from the initial part of the nephron, or the glomerular cap. Many of the renal tubules will empty into collecting ducts that will continue through the medulla towards the renal pelvis, and by doing that, they will eliminate the urine inside the calyces, into the renal pelvis, and finally into the ureters. We'll describe now the vascular structures that are associated to this functional unit, and they are actually part of the functional unit of the kidney. There is a small blood vessel, and this is called an afferent arteriole. It's called afferent with an A because it comes in. Remember, whatever structure comes in to an organ or to another structure is called an afferent, and for this case, it's an arteriole, and will supply the blood to the glomerule. And you can see it's kind of it becomes like a ball of yarn inside of this glomerular cap or capsule. Now, once it branches out, it will branch in after that and will form what is called an efferent arteriole. Will come out of the glomerule as an arteriole. Now, once it's leaving the capsule, it's not going back to the heart immediately. And instead of that, it will branch out again and it will flow into a capillary network that will surround the renal tubule and will form what is called peritubular capillaries. So let's summarize. We start with an afferent arteriole that will branch out and make a ball of capillaries inside the glomerular capsule that will branch in again, getting out of the glomerule and forming a afferent arteriole that, instead of going back and becoming a vein or anything similar to that, it will start branching out and forming this network that you can see around the tubules, that they are called the peritubular capillaries. Now, those peritubular capillaries will transform into venules and will become branching in bigger and bigger veins that will bring back the blood to the vein. If we are looking into the kidneys, each of them will have about 1 million nephrons, and those coil tubes will make up, if we are straightening them out, will cover about 75 miles in length and by saying that, you understand that the fluids that are flowing through the nephrons all the time, and they are exposed to such a length, will be allowed for all these exchanges that need to be done in order to maintain the fluid body balance. This is a microscopic view of a nephron, and you can see how the glomerulus, you can kind of imagine how the afferent loop will branch out and will produce that um, ball of capillaries inside the glomerular capsule. And the tubes around that you see in section, these are the renal tubules. We'll discuss now the process of the urine formation. It's a complex process, and during this process, there will be a back and forth exchange between the bloodstream and the kidney tubules. And it makes sense to be a continuous process of back and forth because the needs of the body can change at any given moment. Um, and by saying that, my body may need more fluids or less fluids depending on the external elements that may require an adaptation to them. And we'll start with what's happening at the level of the glomerular capsule. Probably remember how the blood flow is crossing between the capillary wall and is going into the interstitial fluid as a result of the bulk flow. And that was the process of filtration, if you remember. The same process will happen at the level of the nephron. Instead of that, the fluid will enter the glomerular capsule instead of the interstitial fluid. So look at the image, and you can see how the blood is coming and in through those coil tubes, and instead of going inside the interstitial space, it will go in that glomerular space inside the capsule. In the nephron, this fluid must pass through the walls of both the capillary and the glomerular capsule. And this is facilitated by some gaps that exist between the cells. Now, because of the diameter of the afferent arteriole, it's a little bit larger. Can you see it in the picture? Just look at it. The diameter of the afferent arteriole, it's a little bit larger than the efferent arteriole. It means that more blood will get in at any given moment. So I'm allowing more in. I'm not letting them out. I'm not letting the same fluid coming out quick. So this ensures that I have a continuous increased pressure inside this ball of capillaries. And because it's an increased pressure, remember the bulk flow and the filtration, that will push out the fluids and will promote the filtration. The fluid that is able to be filtered and will enter into the glomerular capsule, those tiny blue dots that you can see in the space, that one will be called from now on a glomerular filtrate. And it will be pushed through the tubules and will start a journey where the composition of this glomerular filtrate and the amount of glomerular filtrate will change several times now. Because of the size of the gaps in between those cells, at the level of the glomerular filtrate, we should not find any kind of blood cells or proteins. Those are molecules and particles that are big in size, and they should not pass through the gaps of the glomerular filtrating membrane. If we see them, if they are present in urine, if we do see blood cells or protein in urine, it means that the gaps of the glomerular membrane, the filters at that level are compromised, and usually it's a sign of a disease. We are moving now with the process inside the tubules, and we'll describe now what is called the tubular reabsorption. Normally, the kidneys will produce about 160 to 180 liters of filtrate, which is huge amounts, right? And that's what happens every day. However, not all of this amount of fluids will become urine. Only a little bit of it will become urine. If you can see, it's 1 to 1.5 liters of urine will be eliminated in terms of fluids. So A lot of water will be filtered and will not going to be excreted. So where does it go? It needs to return somehow to the cardiovascular circulation. Together with the water, we'll have other substances, and sometimes those will be nutrients and electrolytes and other substances, some of them very important for the body that we don't want to lose them. Uh, However, they will be filtered to go together with the water in this glomerular filtrate. So they also need to be returned to the cardiovascular flow. So the process of filtration occurs in the glomerular capsule, and the next step will be to reabsorb part of the water, part of the elements that were filtrated, electrolytes or other nutrients, in a process that is called tubular reabsorption. So the filtrate will start traveling through the renal tubule, and along the way, the water and those electrolytes that the body really needs will start to be reabsorbed. And that will happen through several mechanisms. We can have that reabsorption done by diffusion. And diffusion is that movement of a substance from an area with a high concentration to an area with low concentration. And it's purely dictated by the gradient. Wherever I have high, it will move towards an area where it's low. It can be done through a process that is called osmosis, and this is a diffusion most of the time of the water through what is called a semi-permeable membrane from one area of low concentration to an area with high concentration. So this is kind of against the gradient. And we also have a process that is done through active transport. And this is specific for some materials that will be moved against their concentration. And by doing that, because usually it will be done from a low concentration to a high one, only because those elements are so important for our body, the body is willing to waste energy and to use transporters to move back those essential substances. So those reabsorbed substances will move from the tubular part of the nephron to the interstitial fluid, and after that they will be moved inside the peritubular capillaries to be returned to the circulation. Those substances that are filtered but not reabsorbed will stay in the filtrate and eventually will be excreted in the urine. One example of those type of substances that do not they are not passed back because they are considered as a waste product will be urea and uric acid, that they are byproducts of the metabolism of amino acids and nucleic acids breakdown. We are moving now into another step in the process of forming urine, and this is the tubular secretion. The process of tubular secretion will actively transport some specific substances from the peritubular capillaries into the nephron tubule. So you can see that we discussed number one, which is the filtration. Huge quantities of water with some electrolytes, with some important elements are filtered. Now, in the process of reabsorption, most of the water with most of the electrolytes, most of the essential elements will go back into the interstitial fluid and from them into the capillaries, in some cases facilitated, but most of them will be passive. Now in the tubular secretion, I have again, because you can see the arrows are coming in, going out, coming in, going out. So I have now another process when the body is kind of changing its mind again and says, no, 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 I still have some elements that I need to eliminate. And that will be done for specific substances that will be moved. And those substances usually were not filtered from the blood or at the level of the glomerule, or they were reabsorbed and they were reabsorbed in too high quantities and they still need to be removed to balance their levels. So examples of those will be potassium and hydrogen ions will be moved from the bloodstream through the interstitial tissue into the tubules. So by doing that, because potassium and hydrogen ions, they are acidic, they have a plus associated to them. By doing that, the kidneys will regulate the pH of the body. and this is done by an active secretion of hydrogen ions. Uh, some other elements that will be filtered and cleaned by the body in such a way, they are also the penicillins, some of the antibiotics. So you can see that this is an active process. We'll need energy from the body in order to be produced. And we are moving now into the last stage of forming of development of the urine. And this process, the fourth one, is called the concentration of urine. And you can see how now, again, some elements will be moved back from the tubular fluid back to the peritubular capillaries. Let's see how we do the urine concentration. So we are reviewing what happenings. We are filtering a lot of the fluids in the glomerule. At the level of the proximal tubule, we reabsorb about 65% of the filtered water. And most of it will be done by what is called osmosis. And the osmosis of the water is the result of the water following some solutes, especially sodium. As a result of that, the tubular fluid, that if we analyze the fluid inside those tubules, will have the same osmolarity, concentration of electrolytes, the same osmolarity as the interstitial fluid and the blood. So while we do the reabsorption, we equalize the concentration between those elements, where between the interstitial fluid and the tubular fluid. The ability of our kidney is high in terms of producing urine that is called concentrated. What I'm trying to say is that I have the ability, my body has the ability to save water, to keep and reabsorb as much water as needed and eliminate only very small amounts of urine with high amounts of electrolytes. So it's very concentrated. And this ability is based on a certain structure that is specialized, and it's called, there are some nephrons that are called juxtamedullary nephrons. And those nephrons will have this very, very long Henle loops, the hairpin projection of the tubules that will go very deep into the renal medulla. And that's why they are called juxtamedullary, because they go, as you can see in this image, they can go very, very low. And by having those long loops, they will establish what is called the gradient. It means that the medulla, in terms of osmolarity, in terms of concentration, has a different gradient. And if you look at the scale, you can see how the gradient down in the loop is very, very high. It has the interstitial fluid has a very high osmolarity, a very high concentration of electrolytes over there. So all collecting ducts will use the medullary gradient to produce a concentrated urine. So if I need to concentrate my urine, those will be the nephrons that will overfunction. So the water will move by osmosis down the osmotic gradient. What I'm trying to say is that the water passively will follow the salts. Wherever there is more salts, the water will be attracted to that area, regardless if it's inside the interstitial fluid or inside a tubule. So from the filtrate, it will move because it's very diluted. If you remember, we are filtering about 160 liters per day. From the filtrate that is very diluted, it will move into the interstitial fluid that, if you look close to the medulla, you can see that is over 1,000. And by doing that, it will concentrate the urine that is eliminated. From another point of view, we have another system that helps us in the water reabsorption from the collecting ducts now. So once the distal tubule opens into a bigger tube that is called collecting duct, there is another mechanism that will help my body to save water. And this is by the effects of hormone that is called antidiuretic hormone. And if you remember, this is a hormone that is released from the posterior pituitary gland. What ADH does is not by changing the osmotic gradient. What the ADH is doing is not changing the concentration. The ADH is changing the permeability, is changing the ability of the duct walls to open and allow the water to flow freely. And as a result of that, collecting ducts, remember, it's still the ducts, it's still where we are forming urine. If I'm opening a lot of gates, and ADH, that's what it's doing, is opening a lot of gaps in those collecting tubes, more water will flow out. And as a result of that, the urine that stays inside the collecting duct will become even more concentrated. And this is the function, that's how the antidiuretic hormone is establishing its function in our body. That's why it's called antidiuretic. It prevents diuresis. So as a result of that, we eliminate very small quantities of urine. In the absence of the ADH, the collecting duct cells will have very few channels open. And a lot of water will reach this area and will not going to be reabsorbed. And as a result of that, a lot of fluids, very diluted urine will be eliminated. So if I need to summarize the urine formation, we'll have the following elements. We'll have the glomerular filtration that will move lots of water and solutes from the blood inside the nephron tubule through the glomerular capsule, through the filter. I have a second stage where it's called the tubular reabsorption that will save most of the water, will move a lot of water, and those substances that are useful to our body, that they are essential, and we are moving about 65% of the water by doing that, back inside the capillaries. Now we are moving into the third process, that is the tubular secretion, when we are again eliminating inside the urine all those unfiltered or reabsorbed in more than needed quantities substances, and that they need to be eliminated. And the fourth stage will be the action of ADH at the level of collecting ducts that will concentrate the urine even more and will reduce the volume that is excreted. Let's look now into this question. Uh, the reabsorbed or unfiltered materials can be moved into the nephron by what process? A, filtration, B, tubular reabsorption, C, tubular secretion, or D, osmosis. The reabsorbed or unfiltered materials can be moved into the nephron by tubular secretion. We'll describe now what happens to the urine formed at the level of the kidneys, how it's transported, and how it's after that stored and eliminated to the outside. Once formed in the collecting tubes, it will be eliminated through the um, um, renal pelvis inside the ureters. So the ureters will be a paired organ, one per each kidney. It's a tube. It's very long and slender. It's made out of muscle. It's very muscular, and will have its own peristaltics. Will make tiny movements. Um, because it connects between the kidneys and the urinary bladder, ureters are also considered extraperitoneal organs. They are outside the peritoneum. Their length may vary based on the size of the individual. They are usually between 10 and 13 inches long, and they are not more than um, probably a quarter of an inch in diameter. Very close to the place where they need to join the urinary bladder, because they connect um, between the kidneys and the urinary bladder, about an inch of the terminal distal ureter, the end, the part that connects to the urinary bladder. it will pass this last inch, will pass through the walls of the urinary bladder. And if you please take a look at the image on the bottom of your screen, and you can see, look from the inside of the urinary bladder, and you will see two lines that are joining from the urethra that you can see up on top of it, that they are kind of joining the openings down on the lower part of the urinary bladder. That part I was trying to describe to you, and this is actually passing in an oblique way inside the muscle of the urinary bladder. They will open just superior and lateral, not very far. If you really look into that, they are not very far from the opening of the urethra. And together, they are creating this triangular shape, if you imagine it, that is called a trigon. I was telling you that the urethral wall will have this kind of involuntary thick layer of muscle, and on the inside is lined by epithelial cells. The type of the epithelium in the ureters and also in the urinary bladder is called transitional, and it's a special type of epithelium. It has the ability of stretching and flattening back based on the adapting to the volumes that are going through it. We are at the level of the urinary bladder now, where the ureters are opening in, and they are um, conducting, they are bringing in the urine that is produced at the level of the kidneys. So the urinary bladder is located posterior to the pubic symphysis, is very low in the pelvic cavity. It's extraperitoneal. You can see in the picture how the peritoneum is kind of covering from the outside, leaving everything aside back in the pelvis. It represents a temporary reservoir for the urine. And in a way, it's similar to, if you remember, the gallbladder, that was the temporary storage place or reservoir for the bile. When it's fully distended, it may show up in the abdominal cavity, in the lower part of it. That's why injuries to the abdominal wall, especially when the urinary bladder is full and distended, may result in injuries of the urinary bladder. Otherwise, it's kind of low in the pelvis and protected by the pubic symphysis. The bladder wall has several layers. It will be from the inside out, will be layered by a special type of epithelium. Remember, the transitional one that has this ability of changing its shape to adapt to different volumes. It also forms the epithelium, if you remember from the stomach, all those organs that they need to adapt to different quantities of volume will have this structure of having those folds that are called rugae. They will be seen, those folds can be seen only when the organ is empty, and they kind of straighten out when the organ will be distended. The bladder will fill, and the muscular wall that is very dense and thick when the bladder is empty will become very thin. So this organ has the ability to increase its length from about 2 inches to almost 5 inches, and even more depending on the amount of urine that accumulates. It's very, very elastic and very flexible. Usually, what we call a moderately full urinary bladder will be able to contain about 500 cc's. I was telling you about that structure that is called the trigon. So the trigon is that triangular shape that is formed. It's a region on the posterior wall of the urinary bladder that is made out by the openings of the ureters and the urethra. Once the bladder starts to fill with urine, it will start expanding, dilating, and changing its shape. And by doing that, while the wall is expanding upwards, the trigon will be left at the base, kind of stationary, not moving. And by doing that, it will stretch the urethral openings and will prevent the backflow of the urine back. It's an adaptation to function again. Urethra is that tubular single organ that will carry the urine from the bladder to the outside. It's totally different in males and females, and it's part of both the reproductive system and the urinary system. In male, the urethra is longer than in females, obviously. On an average, it's about 20 centimeters in length, about 8 inches, and proximally, very close to the beginning of the urethra, will go through an organ that is called the prostate gland. And it is joined by two ducts that will carry male reproductive cells, the spermatozoa from the testis, and also the glandular secretions. Uh, from this point, it will lead to the outside through the penis, the male organ of copulation. So in males, the urethra will serve two purposes, both of draining the bladder and conveying the sperm um, um, to the outside. There are some injuries because of the type of and positioning the urethra. There are some typical injuries that can happen to the male perineum. Um, those are called straddle, especially when a male child will fall on or land on a narrow rod or having a beam between the legs. It can happen when they are riding a bike or when they are, if they are involved in any kind of physical activities as constructions. And in this case, the urethra will be pressed and crashed in between that firm object from the outside and the firm part in the inside of the body, which is the pelvic rim. And as a result of that, sometimes the pelvic bones can be fractured also, but usually the urethra will be fractured. The female urethra is very short. On the other hand, it's about 4 centimeters, and it is posterior to the pubic symphysis, and it's contained inside the muscles of the anterior vaginal wall. The external opening of the urethra in females is located just anterior to the vaginal opening between the labia minora. The female urethra will have only one function, while in females, the reproductive and the urinary system are separated, however, they are in very close proximity. Discuss now the process of urination. So the urination can be defined as the process of expelling or voiding urine from the bladder. It's called urination, or the medical terminology for that would be micturition. This control can be both voluntary and involuntary. It starts with all of us as an involuntary process and is controlled by two sphincters. Near the bladder's outlet, there is an involuntary or internal urethral sphincter, and that's made out by a modification in the structure of the bladder smooth muscle. Below this muscle, there is a voluntary or external urethral sphincter, and this is made out by the muscles of the pelvic floor, and this is totally under a voluntary control. Once the bladder will fill with urine, there are some stretch receptors that you remember. We have stretch receptors in all those organs that have the capability of changing their sizes. So the stretch receptors will be stimulated, and they will send impulses to center in the lower part of the spinal cord. Spinal cord, not the brain yet. Motor impulses from this center will stimulate contractions of the bladder wall and relaxation of the urethral sphincter. And as a result of that, will force urine outward. And this is the simple mechanism, the involuntary one. And this happens in infants most of the time. And it's considered a reflex. However, by maturing our nervous system, some impulses from the higher brain centers can overcome this reflex, the spinal reflex. And as a result of that, we have what is called the toilet training, and the urination will become a voluntary, will be initiated by those higher motor centers that may inhibit or relax the spinal centers to produce the act of urination. Let's look now into the product. Uh, what is urine? So urine will be a fluid that is yellowish. Um, if we are analyzing it, we can see that it's 95% water and only 5% will be dissolved solids and some gases. When we are measuring the pH in a freshly collected sample, it should be a normal sample will have a pH of 6. However, and there are a lot of elements that can contribute to a change in the urine pH, the range can be between 4.5 and up to 8. So it can be, we can range from acidic to very, very alkaline. So one element that may contribute into those variation is the diet. Also, the diet may change the color and also the odor of the urine. Um, let's say um, people that are eating asparagus may have this kind of pungent odor in the urine after that. And in terms of color, the color can be changed by consumption of beets. A lot of people, especially those that they are not eating beets on a um, not necessarily on a daily basis, but on a more consistent way, and they have beets once in a blue moon, may become extremely worried when they see that their urine becomes extremely reddish, and they can become scared because they believe that this is blood. Let's look into the dissolved substances. Whenever we are describing those, we are looking into what is called the specific gravity. Uh, so the specific gravity of water and just water will be 1. It means that has no particles dissolved in it. Whenever we start to dissolve particles in water, the specific gravity will increase. So for the urine, when we measure that, we get information about the number of particles that will be dissolved in that fluid. It can be very close to 1, like 1.002, that's very dilute type of urine, and up to 1.040, which is very concentrated urine. Again, it's just 5% of the whole amount, so you cannot expect to be more than 40. However, you can see that just by looking at this, you can see how many particles we have diluted inside the urine. There are some normal um, uh, constituents, components that we will, when we analyze the urine, we will see in urine and will not gonna become concerned about anything. First, and probably the most important one I was describing to you even at the beginning is all the nitrogenous waste products that they are results of the protein metabolism. We'll have urea that is formed from the amine group that is released in the processing of the proteins. We have the uric acid that is the byproduct of breaking down purines, which are found in nucleic acids. And we have the creatinine that is also a product of destruction of proteins and especially muscles. We see electrolytes normally. We'll have sodium and chloride, sulfates and phosphates, and we can see pigments. We do want to see pigments. We have a pigment that is giving the yellow, specific yellow color to the urine, and is a result of the metabolism of hemoglobin, and is called urochrome. And this is the main pigment. We may have small amounts of bilirubin or other bile pigments. Also, some B vitamins, if they are ingested and eliminated in the patient urine in high quantities, may give a yellowish color. We can see vitamin C. Some food dyes may color the urine. Some drugs can alter the color of urine, and it's a good habit to alert to advise and teach the patient about those changes. Otherwise, they will become extremely concerned. We describe the normal ones. Now we need to describe what we don't want to see, what means an abnormal constituent, and what may signal that there is an issue with that individual. Um, we do we look at the constituents when we are doing what is called the urinalysis, and this is part of the regular lab test that we are doing in most of our patients. Probably the first one that is very common, it will be the glucose. And the glucose will signify in most patients a presence of diabetes mellitus. Um, the presence of glucose in urine is called glucosuria. Normally, in a patient that doesn't have high levels of glucose, glucose will not going to be filtered because it doesn't get to that point of being in such high quantities that the kidney needs to filter it. Once the levels of glucose becomes high because of the tissue resistance or the inability of insulin to be secreted at normal quantities, the glucose will accumulate and will be filtered and will show in urine. Albumin is a second component that we don't want to see in the urine, and it will signal a damage to the wall of the glomerule or at the level of the glomerular capsule, because the albumin, I was telling you, it's a big particle, so it's not supposed to be filtered through the small eyes of the gaps that exist in a normal nephron. The presence of the albumin in urine is called albuminuria. Um, in the same boat with the albumin will be blood or any types of blood components, blood cells, and especially the red blood cells. Red blood cells should be big, and we shouldn't see them as filtered. We can see it as when we have blood present in, it can be macroscopic, it can be frank blood, red blood in the urine, usually from a trauma or an injury to any part of the urinary system, from kidneys to the bladder through the ureters, or it can be what is called microscopic. It's not something that we see frankly as red, but we can identify when we are analyzing the urine through a microscope, and that's the presence of red blood cells that will escape through a damaged filter membrane in the glomerule. Presence of ketones. If you remember, those are the byproducts of fat metabolism, fats that are incompletely oxidized, and they will show up in urine whenever they are in high quantities, and they show up whenever fats are used in excess to produce glucose. And if you remember, not necessarily to produce glucose, but to produce a source of energy whenever glucose is not available. And if you remember this, in one of the situations like that, besides fasting, it will be the diabetes mellitus that is uncontrolled. White blood cells that can come as pure pus may signify an infection at any level in the urinary system, and the presence of them in the urine will be called pyuria. Also, we may see casts, and those are solid materials that will be, they're called casts because they look molded, and they kind of look like they were molded inside the tubules of the nephron. And they are a combination of cells or proteins, and whenever we have them in large numbers, that signifies a condition or a disease of the nephron at the level of the tubules. Which structure is responsible for voluntary control of urination? A. Trigon. B. Internal urethral sphincter. C. External urethral sphincter. Or D. Urinary meatus. The structure responsible for voluntary control of urination is C. External urethral sphincter. We'll start discussing now conditions that are affecting the urinary system. And we'll start with those that are defined as obstruction or structural disorders. Any obstruction in the urinary tract that may result in an impaired transportation of urine through the tubes and eventually it through the ureters and the urinary bladder will result in a condition that is called hydronephrosis. And hydronephrosis is the distension of the renal pelvis and the calyces along with that. Um, and it will result in an accumulation of fluids. If the obstruction is long-standing and it will not going to be removed quick, this increasing pressure will be transmitted to the kidney tissue, and the kidney tissue in time will become damaged from the pressure and malfunction, and as a result of that, the kidneys will be permanently damaged. In terms of causes for the hydronephrosis, the most common ones will be scar tissue from injuries, kidney stones that are lodged and impair the transportation of urine, or tumors. I was just saying something about kidney stones. They are called also renal calculi, and those are deposits of tough substances, usually calcium or calcium salts or uric acids that will precipitate, will deposit themselves out of the urine instead of staying dissolved inside the urine and being eliminated. The most common place for development of urinary calculi will be in the renal pelvis. Um, However, they may form in the bladder where they can start very small in the renal pelvis and they will travel through the ureter and continue developing inside the urinary bladder. There are some risk factors that are associated with the development of renal stones, and that's family history, patients that are exposed continuously to dehydration, obesity, and some urinary tract infections, some bacteria will change the pH and will favor the precipitation of um, those salts. The stones can be in a variety of sizes, from really tiny grains that we call them sand, to those that can be very, very big, and they can even take the shape and kind of mold the shape of the renal pelvics and the calyces. Those that will mold the shape of the calyces are called the staghorn calculi, and you have an example in picture B. The stones usually will cause pain, especially when they are traveling and moving from their initial position, and they may cause temporary obstruction in the urinary system. If a small stone will dislodge from the renal pelvis and will start traveling through the ureter, can lodge itself in different levels of the ureter and will irritate the mucosa, will scratch the mucosa, will cause what is called a spasm, a hypercontraction, because of the pain caused and the injury caused locally on the ureters. And as a result of that, the patient will perceive an excruciating pain, and that is called the renal colic. The relief for this pain is usually um, um, achieved by morphine or something that is a very powerful drug. So this is a very intense type of pain. In terms of treatments, um, we can do surgery for those that are very, very big to remove obstruction. We can do what is called minimal invasive procedures by looking with a camera inside the bladder, gaining access through the urethra inside the urinary bladder, and from there through the ureters, and trying to crash the stones and remove them through endoscopic procedures. Or we can use what is called the lithotripter, and you have here the image of it. It's a machine that from the outside is using waves that will um, hit the flank, will hit the area of the kidney, and by those hits and vibrations will try to break down the stones, making them very, very tiny as sand. And by doing that, the urine will start flowing and will flush them out. The procedure is called a lithotripsy, or the full name is the extracorporeal shock wave lithotripsy. We'll look now into some structural abnormalities. So there can be many levels that the urinary system can manifest with different types of congenital abnormalities. The most common ones will be at the level of the kidney. Um, about 10% of the population will have some type of kidney abnormality. Um, the hypoplasia, uh, the renal hypoplasia, represents a kidney that is abnormally small. Um, it is fully formed, however, very, very small. It may maintain the function, however, um, it may provide just limited, it may be limited in its ability to function because it's smaller than expected to be. On the other hand, we have what is called a renal dysplasia. And in this case, the kidney has malformation in terms of structure or connective tissue, and as a result of that, is malfunctioning. Both of them eventually may result in renal failure. Other type of abnormalities may include narrowing of the ureters at several levels, and they are described as strictures. Um, a ureterocele is a bulging um, into the bladder of one of the ureters. There can be some urinary flow impairments as a result of obstructions at the level of urethra. Um, Especially in males, it's obvious, and I'll show you a picture in a second. There is a condition that is called the hypospadias. There is an abnormal opening of the urethra that instead of being opening at the tip of the penis, it will open on the ventral side of it, um, anywhere in between the perineum and the tip of the penis. Um, the correction is surgical. So this is the condition that I was talking before. It's called the hypospadias. You can see how the urethral opening is not at the tip of the glans, but anywhere. It can happen anywhere, all along in between the root, the base of the scrotum, and the tip of it. It can be also associated with strictures, with narrowing of the opening of this abnormal positioned urethra. It's obviously that in this case the urethra is short and needs to be reconstructed and rebuilt and developed and brought it to where it needs to be at the tip of the penis. Inflammatory conditions. Um, so um, any part of the urinary system can be prone to infections. We call UTIs or urinary tract infections um, those infections in the urinary system that they can be lower or higher depending on the organ that is affected. We have what is called urethritis, or that inflammation slash infection of the mucous membrane at the level of the urethra. Most commonly, urethritis are a result of sexual activity and sexually transmitted conditions, um, and in sometimes may be due to poor hygiene and will be associated with E. coli. And E. coli is one of the bacteria that is normally present in our feces. Um, so it's a kind of a self-contamination of the patient due to poor hygiene. Um, Urethritis can also be caused by viral or fungal agents, especially in those patients that are immunocompromised. Cystitis is the inflammation of the urinary bladder that is very, very common in females, way lower in males. And the cause for the cystitis and the high incidence in females is because of the short urethra and the close proximity between the perineum in female is very, very short. Also, catheterization can be an additional risk factor for development of cystitis. In terms of symptoms, urethritis and cystitis, they will share some elements in common. The patient will complain about pain, urgency to urinate, an increased urinary frequency. And when I say urgency, is that sensation that they are not able to hold up until they will be able to reach the bathroom. Another risk factor for an increased chance of developing cystitis is what is called retention of urine. And because the urine stagnates, it's hold into the bladder for a long time, bacteria may have a way to develop and increase in number. There is a special type of cystitis that is called interstitial cystitis. That will cause um, a specific type of pelvic pain that is providing, I mean, like the patient is complaining about a very specific type of discomfort before and after urination. And this is because it's an active spasm of the muscles of the um, bladder in this condition. The cause is unknown. Um, there is no bacteria usually involved, and because of that, the antibiotics will not going to be effective because it's more a pathology of it's a change in the mechanism of the reaction of the muscles. Pyelonephritis. Um, some of the bladder infections that are not correctly treated or not treated at all or not treated in time may ascend, may move upwards through the ureters to the level of the kidneys. And as a result of that, when there is an infection of the renal pelvis and or kidney tissue, that will result in what is called an acute pyelonephritis. Um, and the risk factors for that will be urinary stasis, those that have they are not emptying their bladder efficiently or completely, and the backflow, which is the reflux from the bladder towards the kidney. There are two types of pyelonephritis. It can be an acute one and a chronic one. Um, there is very rarely that the blood will bring the bacteria that will locate themselves at the level of the kidneys and will produce this infection. Is usually an upwards transmission of bacteria. Antibiotics are efficient in the treatment. Whenever it develops into a chronic form, this is a little bit more serious and seen in those patients that have chronic issues of the urinary system, like someone that has um, um, prostate, a hypertrophic prostate, and they will not eliminate urine efficiently for a long period of time. And from chronic pyelonephritis, that can progress to a more permanent and progressive kidney damage. And as a result of that, not only that the patient will develop the renal failure, but also may develop high blood pressure, continuous loss of protein in the urine by um, um, that because the glomerule will be damaged in addition to that, and an incapacity of concentrating urine. And by continuously removing dilute urine, they will be predisposed to dehydration. The last one will be the glomerulonephritis. It's an acute condition. It's usually called acute post-streptococcal glomerulonephritis because, and this is a very common condition of the kidney. It's usually following an acute infection with strep, usually strep group B, usually a throat infection, and it's very common in children. It will develop about 1 to 4 weeks after a throat infection. And the mechanism is a result of, it's an immune mechanism. The antibodies that are formed in response to the strep injury will start attacking the glomerular membrane and will cause injury at that level. As a result of this immune attack, the glomerules will become leaky. The filter will become destroyed and the gaps will become very big because some cells will be destroyed. And along with that, by enlarging those gaps, protein will be lost, especially albumin. And as a result of that, we'll have albuminuria. Red blood cells will show up in urine as hematuria. And as a recovery from this condition, most of the times the patients will have a certain degree of kidney damage. So it's very important to treat very quick and very efficient strep infection in order to prevent this complication. neoplasms. So um, you see here the title is bladder tumors. However, the kidneys tumors are also a condition that can be encountered in our patients. They usually grow slow, uh, but they will invade very rapidly once they are formed. And the most common symptoms will be blood in urine and a dull pain in the flank where the kidney is located. Um, the treatment is the surgical removal of the kidney, and usually if it's done, if the diagnosis is performed in an efficient way and in early stages, the prognosis for those patients will be good. Keep in mind that chemo and radiotherapy is not efficient in this type of cases. When we are looking at the bladder tumor, they are kind of common, seen in men over age 50, and they start as polyps. They will start as benign papillomas, and they can develop into a variety of tumors. About 90% of that cancer will start in the epithelial lining. And that's a common denominator for a lot of systems in our body. Most of the cancers will have their start point in the epithelium, in the mucosa. And this is because this area, that layer of cells, has the highest rate of return, of turnover, of being eliminated and produced new. Um, some causes that will, some risk factors for bladder tumors will be exposure to some dyes, is aniline dyes, chronic infestation as infestation with schistosoma. This is a parasite. Heavy cigarette smoking, presence of urinary stones sometimes. In terms of symptoms, the patients will present with hematuria, and a lot of times is not painful one, and they will have also frequent urination. The diagnosis is done by performing cystoscopy with biopsies. Cystoscopy is a type of endoscopy that we can look inside the bladder and establish a diagnosis and also take biopsies for pathology. The treatment will be the removal of the tumor. That can be done also by cystoscopy, minimally invasive, followed or not by local chemotherapy. In some extreme cases that are more aggressive, we can add to that um, local radiation. In some extreme cases, the removal of the urinary bladder may be needed, and that is a surgical procedure that is called cystectomy. Um, and whenever we do that, we will need to have a solution to do something with the ureters. The ureters need to open somewhere because the kidneys will continue to produce urine. So we can either have a ureterostomy to bring the ureter to the level of the skin and connect it to the skin and have a bag that will collect the urine all the time. Or we can perform an ileostomy, which is a diversion procedure. Here you see how an ileal conduit looks like. It's a piece, it's a segment of the ileum that it's disconnected from the small bowel, and the small bowel is reconnected to maintain the continuity. And this segment of ileum, one side of it is completely closed, and the other one will be open to the skin, and both of the ureters will be implanted, and by doing this, we have a kind of a temporary reservoir. And there are a few techniques in order in how to perform this. And because it's a stoma, it's an ileostomy, the patient will need to have a bag. Polycystic kidney disease is a genetic disorder in which at the level of the kidneys, there will be a multitude of fluid-containing sacs that will develop. Um, those sacs can develop and become extremely large at a certain point with kidneys that they can weigh up to 30 pounds. Those fluid-filled sacs will take the space from the normal performing renal tissue, and as a result of that, the kidneys will become an organ full of scars and will not going to be able to perform the main activity uh, of producing urine and maintaining the normal blood pressure. And as a result of that, the patients will have chronic renal failure and high blood pressure. Usually, this condition is running in families, and there is no treatment except for the fact that by knowing that they will um, have as an end result chronic renal failure, the patients will need dialysis, and in some cases we can try um, to perform in those patients to have a kidney transplantation to prevent them from being on dialysis. And the good thing is that on the transplanted kidney, the disease is not recurring. The renal failure. We have two types. We have chronic and acute renal failure. When we are looking at renal failure, this can result from a medical or a surgical emergency or from some type of exposure of the tubules to toxins or some type of injury. The acute renal failure will be characterized by a sudden and very serious decrease in the kidney function, up to the total absence of producing urine. And as a result of that will be an imbalance of electrolytes and the acid base in the body. Um, Most of the times, acute renal failure is a serious complication of other severe illnesses, and in most of the cases, it's fatal. The chronic renal failure, on the other hand, is that gradual onset and loss of function of the nephrons, along with losing more and more nephrons and their function. The kidney will lose the ability of performing the function and producing urine. As a result of that, the patient will reach what is called the renal insufficiency. As a result of that, we can have a wide range of symptoms in it. It can be, we can see dehydration in some of the patients because the nephrons are not able to concentrate the urine anymore, so huge quantities of water will be lost. We can see edema as a result of losing albumin, and that will be an accumulation of fluids in the tissues. Electrolyte imbalances with retention of sodium and potassium, hypertension as a result of sodium and water retention, anemia as a result of not producing anymore the erythropoietin hormone that is necessary to activate the red bone marrow, and uremia by because of the incapacity of the kidneys of cleaning out the urea that is produced in the body. Whenever the urea reaches high levels, the body is changing its structure, is metabolizing it into what is called ammonia in the stomach and in the intestine, and as a result of that, will cause ulcerations and bleeding in those patients. What can we do for those patients? Well, we have the option of doing what is called a dialysis, and if I need to describe the dialysis, this will need to be described as the separation of any type of dissolved molecules based on their ability to pass through a filter, which is usually a semi-permeable membrane. It's an artificial way to recreate a filtration system similar to that the kidney is offering, the nephron is offering to us in a natural way. The patients that are going through that need the dialysis can do that as hemodialysis, or a different type will be the peritoneal dialysis. In hemodialysis, um, that can be done. Usually, it's on a schedule that may involve something between 3 to 5 to 6 hours of procedure, 3 times a week or 2 times a week. It depends. Every single patient it's a little bit different. There will be some patients that will prefer to do the dialysis during the night, and they can do that in their homes, or they can go during the day in dialysis center. In some centers, they can even offer dialysis overnight. In order to perform this procedure, the patient will need to have surgically created what is called an arteriovenous fistula, a communication between an artery and a vein in their arm, in order to have an access port because the blood during dialysis is removed, is filtered through a machine that will clean out all the waste products, will reduce the level of toxins, and will return to the patient blood flow into their bloodstream only the necessary amount of blood, by also eliminating part of the water, because they will need to have that filtered too. Another option will be what is called the peritoneal dialysis. And this type of dialysis, instead of using a filter that is part of a machine, will use our peritoneum as a filter. It has, our peritoneum inside the abdominal cavity has this ability of filtering. And it's a filter with a huge, not huge, but a very big surface. So the dialysis fluid, this is a procedure that can be done by the patient in their home, and usually they are doing that daily and sometimes twice every day. So the dialysis fluid will be introduced through a catheter that is also surgically placed in the patient's abdominal cavity. And they will introduce the fluid, will let the fluid sit inside the peritoneal cavity for a certain amount of time, and they will, through the same catheter, they will drain that out. No matter how you're looking at that, being a dialysis patient, regardless if it's hemodialysis or peritoneal dialysis, it's a very complicated and stressful way of life, because all those associated, because of the time that it takes to do that, and because of all the risks and the complications that can come associated with both of those methods. And more permanent solution for renal failure patients can be given by a kidney transplantation, and that can be a final kind of treatment for any type of kidney failure. However, kidneys, it's easy to match people to have a kidney transplant. However, it is sometimes hard to maintain that healthy kidney that the patients will need, because those patients already have a lot of associated background conditions, and a transplant patient will need for their lifelong existence immunotherapy, immunosuppressive therapy, to maintain the kidney that was transplanted and to prevent a rejection reaction. This is showing you how the hemodialysis works. You can see that in the arm of the patient, there are two tubes. One will take out the blood, and there will be a pump that will suck and recirculate the blood. The exchanges are going through a machine that has that semi-permeable membrane and has a dialyzing fluid, because again, we need to simulate in those machines the same conditions that happen inside the kidney, where the nephron has the interstitial fluid and the tubules. So it's a simulation of that situation. In the dialysis, in the peritoneal dialysis, our body is actually using as a filter the peritoneal cavity, and you can see the dialysis fluid, the left image will be at the beginning when the patient is instilling the dialysis fluid into the peritoneal cavity, and after a certain amount of time, the same bag will be lowered on the floor, and all the fluid that was instilled was pushed inside the abdominal cavity will be drained out. Urinary incontinence represents an involuntary loss of urine, and there can be a wide range of conditions that can lead to incontinence for neurologic conditions, any type of trauma to the spinal cord, to weakness of the pelvic muscles and impaired bladder function, or even some types of medication can create the condition. We have a few types of urinary incontinence. We have what is called the stress incontinence, or the weakness. It's more an incompetence of the urethra, and that allows that small amounts of urine will be lost or will escape whenever there is an increased activity that will produce a high pressure inside the abdomen, like in coughing or sneezing or exercising or lifting. Is typical for those women that have a lot of vaginal birth, and they may have now a weakened pelvic floor. We have urge incontinence, or an overactive bladder, and that's an inability of controlling the bladder contractions. Um, and that happens even to very small amounts of fluid, of urine accumulating in the urinary bladder that will stretch the bladder wall and will create that feeling of necessity of running to the bathroom. We have what is called overflow incontinence also, and as a result of a neurologic damage, or in some cases due to urinary obstruction. Um, that as a result of that, the bladder will overfill up to the point when the excess pressure in the bladder will result in some type of involuntary urine loss. And we have another type that is called enuresis, which is an involuntary urination, especially during the night. Or it's popularly called the bedwetting, and it's usually described in someone. It's usually a child that was toilet trained, and at a certain point they are losing this ability and they are starting to wet the bed again. Aging and the urinary system. Just like any other system, urinary system will be exposed to aging as progressively more water will need to be excreted, and there will be a loss of nephrons throughout our life. Beginning at about 40 years of age, there is a decrease in their number, and especially in the size. And with that, there will be a decrease in the function. More than half of them will be completely lost before the age of 80. Also, in addition to that, there may be an increase in the blood urea nitrogen as a result of other associated conditions. Elderly are at higher risk to develop urinary tract infections. Um, Women at childbearing age may be exposed to risk factors of damaging the pelvic floor muscles, and as a result of that, having urinary tract issues later in life. With increased age, enlargement of prostate, common in older men, will cause obstruction, and as a result of a buildup back pressure in ureters and the kidneys, may damage the structure of the kidneys, in addition to the rest of the changes that happen with age. Um, the prostate need to be treated as soon as possible in order to prevent all those changes. Another thing that happens with age will be a decreased bladder capacity because of a loss of elasticity in the tissues, and the decreased muscle tone in the bladder and also in the urinary sphincters. In some patients, resulting even in what is called, and I just described it before, what is called the incontinence.